March is National Endometriosis Awareness Month, and now endometriosis impacts more than 11% of women between the ages of 15 to 44. So today on Lunchtime Live with the Center, we are talking with Dr. Lawrence Engmann about this condition and how it affects your fertility. Dr. Engmann, nice to see you and welcome back.
Thank you for having me.
Yeah. So what is endometriosis?
So endometriosis is a condition where the lining of the uterus, which is called endometrium, is found outside the uterus. So it's found in the pelvis. So the lining of the pelvis is found on the ovaries, the fallopian tubes.
Yeah, and so it's found on. Can it be found on other organs as well?
Oh yes, it can be found on the bowel. Around the sigmoid colon. At times, it may be found on the liver as well, the diaphragm. But the commonest areas are usually in the pelvis, the lining of the pelvis, the ovaries, and the fallopian tubes. If it's found in the wall of the uterus, then it's called adenomyosis. So it's a little bit different. That endometriosis is mainly in the pelvis.
Is there any understanding of what causes endometriosis?
So there are several theories. The most common theory is what we call a retrograde flow of the menstrual blood into the pelvis. And what happens is the endometrial cells then implant on the pelvis. And then what happens is there's new vessel formation, there's fibrosis, and there's thickening, scarring, and then it may result in inflammation. And so typically what happens when there's implantation of the endometrial cells in the pelvis is that it may become thickened during the cycle. And then at the time of the menstrual flow, it may also bleed a little bit. And then that may result in scar tissue formation. And at times, it may also invade the sensory nerves, and so it may result in pelvic pain.
You mentioned retrograde flow. Is there something that can be done about retrograde flow, and what is that exactly?
So basically, when you have a period, the endometrium or the lining of the uterus is shed through the cervix. But at times, because there's a connection between the uterus and the fallopian tube and the pelvis, at times part of that flow goes through the fallopian tube into the pelvis. And unfortunately, there's nothing that you can do about it. But there are some predisposing factors that may enable the endometrial cells, when it falls on the pelvis, to actually induce that inflammatory response that may result in new vessel formation and implantation of the endometrial cells.
And what are some of those predisposing factors that you mentioned?
There are several reasons. It may be some genetic reasons. Okay. We also know that there are certain groups of patients who are more predisposed to having endometriosis than others. And several other reasons that have been identified in women with endometriosis.
And what are some of the symptoms? How do you know when someone has endometriosis, or how would someone know they have endometriosis?
So because the endometriotic cells invade some of the sensory nerves, it may result in pelvic pain. So it may be cyclic pelvic pain, where every month they may have pain either mid-cycle or at the time of the menses. So they may have severe menstrual cramps, and also may have pain with intercourse. So the pain may be cyclic or it may be chronic. Some patients have pain all the time, or it may be related to the time of the period, or they may have pain during intercourse. Some patients who have endometriosis on the bowel may have pain when they move their bowels as well. But the most common presentation is pelvic pain. Now, some patients also present with infertility, so difficulties with getting pregnant. And that's how most of the patients that we see, that's how they will present.
So do they tend to come to you already having been diagnosed, or or is it something that you tend to do?
No, so it's variable. Some patients have already been diagnosed, but there are several patients who are totally asymptomatic, where they don't have any symptoms at all. And it's being estimated, depending on the study you read, between 30 to 50% of patients who may be asymptomatic may have endometriosis. In our population, maybe about 15 to 20% of women with unexplained infertility may have endometriosis. And so some of these patients may not have any symptoms at all. Some patients may present with pain, with their periods of pain with intercourse, and then you suspect that they may have endometriosis and then can do further workup.
And how do you diagnose them? How do you diagnose this if needed?
So the diagnosis is based on history. So you may suspect that they may have endometriosis because of the symptomatology. At times with pelvic examination, you may feel some thickening in the pelvis that may lead you to suspect that they may have endometriosis. And then a pelvic ultrasound may show an endometrioma, which is endometriosis of the ovary containing fluid. And then you may be suspicious that there may be endometriosis. However, the standard diagnostic criteria is by doing a laparoscopy. So a laparoscopy is basically a day surgery, and it's done under general anesthesia. So we make an incision around the umbilicus and then insert the laparoscope, which is a very fine instrument. It's like the width of a pencil or a pen. And it has a light source at the end and a camera. And then you go into the pelvis and then have a look and see whether there is any evidence of endometriosis. And then it can be treated at the time of the diagnosis. So the standard criteria for diagnosis is by doing a laparoscopy.
And there are different stages of endometriosis, and what do those stages entail, or what do they mean?
So it means it depends on the severity of the endometriosis. So there's stage 1 to 4. Stage 1 being mild endometriosis, where there are some implants of endometriotic lesions in the pelvis. It's usually powder band brownish lesions when you do a laparoscopy. So it's basically the staging is basically based on doing a laparoscopy. Stage 4 is the most severe, where there is distortion of the pelvis. There's a lot of scar tissue formation. There may be cysts in the ovary consistent with endometriosis.
And so why is endometriosis, why is it associated with infertility? How does that work, or what is the correlation there?
Well, there are several reasons. So the first reason is if there is a distortion between in the pelvic organs. So there's a distortion between the ovaries, a relationship between the ovary and the fallopian tube because of scar tissue formation, and it will affect the release of the egg into the pelvis for the fallopian tube to pick it up. So that typically occurs in the severe type where there's a lot of scar tissue formation. There are several reasons why in cases of mild to moderate where there's not a lot of scar tissue formation, there still may be infertility. And there are several theories. One theory is that it may affect the follicular development, so the way the follicles develop and the eggs are released. There may be also release of inflammatory factors that may affect implantation, and therefore the embryo may not implant. And it may also, especially in severe cases, may affect the quality of the eggs, such that there may be poor quality embryos that may not implant.
Okay. And you had mentioned inflammatory factors. Is that why endometriosis is associated with pain? Is that where it comes from?
No, I think the inflammatory factors is mainly related to infertility. One of the major reasons why endometriosis causes pain is that the endometriotic lesions invade the sensory nerves. So if you have something irritating the sensory nerves, then that could potentially result in pelvic pain.
Okay. So how do we treat it in our office?
So the treatment really depends on the presentation. So if the main presentation is pelvic pain and the patient is not desiring to have children, then the treatment is different from somebody who presents with difficulties with conception and wishes to have children. So if it's mainly pelvic pain, the management is mainly medical. So that could include oral contraceptive pills, and then medications such as Lupron that suppresses the release of FSH and LH from the brain that prevents ovulation. The whole idea is to reduce the estrogen secretion. Because endometriotic lesions depend on the secretion of estrogen to develop. So the idea is to suppress estrogen. So we give the oral contraceptive pill. But if you do that, the patient cannot get pregnant. So that's why we use it mainly for patients who have pelvic pain and are not trying to get pregnant. For patients and also the other modality of management is surgery. So if a patient has severe endometriosis and have pelvic pain, the ultimate treatment is doing a laparoscopy and resecting the endometriotic lesions, whether in the pelvis or in the ovary. However, patients who have difficulties with conception, the first line of treatment is assisted reproductive technology. It's been shown clearly that intrauterine insemination with ovulation induction is the first line of treatment for patients with endometriosis. However, patients with severe endometriosis, usually in vitro fertilization, will give them the best chances of conception.
Okay. Now, when someone comes to you, if someone has endometriosis or thinks that they have endometriosis, but they're not necessarily looking to get pregnant yet, would our center be the first line of, first person they call or would they talk to someone else?
So if they have, let's say they have pelvic pain and they're not planning to get pregnant, we usually work with surgeons who are specialized in endometriosis surgery. Okay. And so they call our office and we'll give them the number to call them. But we work in collaboration with them and then they will arrange the surgery. If they're trying to get pregnant, then we see them and go through the workup and determine whether they need to have surgery or not.
Okay. And so someone's asking, for inflammation in endometriosis patients, would you recommend prednisone in an FET cycle after 2 unsuccessful FETs, 1 chemical and 1 failed?
That's a very good question. And there's a lot of controversy in terms of the impact of endometriosis on implantation. So somebody who's done FET a couple of times and haven't been able to get pregnant, and there is documentation that they have endometriosis and they have good quality embryos. So let's say they've done PGT, which is pre-implantation genetic testing, and they have normal embryos but haven't been able to get pregnant. One modality is to do Lupron, which is Lupron to suppress estrogen for about 2 to 3 months. There's clear evidence regarding that. There's no clear evidence regarding using steroids and in patients with endometriosis. There's some theory that steroids may help with inflammation in certain groups of patients, but the evidence is not convincing in terms of endometriosis and steroids.
Okay. I'm sure people want to know, is endometriosis, does that mean that you will automatically have infertility?
No. It doesn't mean that if you have endometriosis, you're going to have infertility. There are several patients with endometriosis who conceive spontaneously. And we have several patients with endometriosis who have infertility and may get pregnant with intrauterine insemination without necessarily requiring IVF.
And you mentioned taking Lupron. Is that a typical medication that's recommended for in a patient's protocol with endometriosis? You
mean your IVF protocol?
Yes.
So in the scenario I'm talking about is the question that was asked where a patient has had recurrent implantation failure and there is documentation of endometriosis, either by surgery or at times we do a new technique where we do a biopsy to determine whether there are markers of endometriosis.
Okay.
And in those case scenarios, there are some studies that have suggested that going on Depolupron, so Lupron shots for 2 to 3 months, may improve implantation because it suppresses endometriotic growth and also may have some anti-inflammatory properties.
If you think someone has endometriosis, do you recommend this endometrial biopsy that you just referred to?
No. So if someone has endometriosis, the standard of care is do a laparoscopy and confirm whether they have endometriosis. If that's the question, in certain situations where a patient doesn't have any symptoms of endometriosis and have undergone a couple of cycles of frozen embryo transfer, like the question that was asked,
okay,
then at times we may do a biopsy. There is a marker that has been associated with endometriosis. And if that's positive, then we will recommend going on Depolupron. Okay. But endometrial biopsy is not a diagnostic tool for endometriosis.
Okay. Well, the rest of the questions are actually comments about how awesome you are. Dr. Engmann is the best, most caring, kind doctor. We love him. And Dr. Engmann is the man.
I love all of them.
Yeah.
I love my patients, yeah.
Well, thank you, Dr. Engmann, for sharing all of this.
Thank you. Thank you very much. Take care.
And join us next week the same time and place on Lunchtime Live at the Center. See you then.
Thank you. Bye-bye.
Bye.